Hi, everyone. It's Wendy from Eagle Pass Heroes. We are a local nonprofit here in Eagle Pass, Texas, and we are so thrilled today to come on and talk about something that we really find important and really just want to help provide a resource. And we are so thrilled to have Mr. Diaz here and share his expertise and really giving us some tools and resources on what trauma informed care is and what it is that we can help address this. As we work and service children with individuals with disabilities, we understand that trauma may happen across the span. It's not limited into one section of individuals. And so we're very excited to learn about this so that we're able to help be a resource to everybody in our community. So thank you so much for joining us. And we're so excited to have you present. So without further ado, I'm going to go ahead and turn it over to you. Thank you.
Thank you so much, Wendy, and thank you so much to Eagle Pass Heroes for having me on today. I am super excited to be able to share this information with you. Number one, because as a trauma survivor myself, I understand the importance of weaving trauma-informed care into absolutely everything that we do. So regardless of whether, and we're going to be talking about, whether you're a parent, whether you're a provider, whether you're another type of caregiver, anybody that interacts with your child and including your child as well. It's important for us to understand trauma and the effects of trauma and also how we can heal and recover from it, right? And so with that being said, I want to start off with a quote from Rumi. So whenever we're talking about trauma, sometimes it can get it's a little bit of a somber topic, right? Like we start to talk about layers of abuse, and we start to talk about the bad things that can happen because of trauma, and so it can get quite heavy. And so before we even open up this topic, I want to start off with this Rumi quote, just because I love all things Rumi, right? But so I want us to consider and to think about the cure for the pain is in the pain. And so I often tell people trauma is a very special and unique opportunity for you to create meaning around it. So whether it's for yourself or those around you or both, there's a way that we can use trauma, or if you've been exposed to trauma, there's a way that we can use trauma to create something very beautiful out of it. And so I want us to consider that as before we begin this topic. And I know that trauma is quite a bit of a buzzword, right? So we often think about trauma, and there's multiple versions of what we may or may not identify or traditionally think about as trauma, right? So, what is trauma specifically? Trauma, in order for us to consider trauma, there are two types of what we call precipitating events. Either the experience of a threatening event, so that may be the experience of violence, right? And that may be physical violence, abuse. It could be emotional, physical, or sexual, or neglect, right? It could also be the experience of a natural disaster. So maybe you survived a tornado or something of that nature. Um, the experience of physical pain, injury, or illness. So that may be bodily harm to yourself or surviving cancer as a child, or it may also be parental abandonment. Now, there's another type of precipitating event, which may be the witnessing of threat or danger to another, particularly to someone that's close to you. So that may be experiencing violence in the home or in the community. So if you grew up in a community that is ridden by violence or gang members, or if you grew up in a home where your father abused your mother or vice versa, that might be, or either of your parents abused each other, regardless of their gender. That might be your experience of, of trauma. There might be a family member attempting or actually committing suicide, or going through substance abuse in the home. So how prevalent is it when we think about childhood trauma? And mind you, trauma can happen throughout the lifespan. For purposes of this presentation and for the audience of this presentation, I did heavily focus on childhood trauma and the effects of childhood trauma. But we will later talk a little bit about sometimes childhood trauma can predispose us for different types of trauma and varied types of trauma as an adult. But how prevalent is it? So actually 26% of children in the US will witness or experience a traumatic event before they turn 4. Approximately 60% of adults report experiencing abuse or other difficult family circumstances during childhood. And this is from a very famous study called the adverse childhood experiences. When we look at trauma, that's kind of like the gold standard to the way that we evaluate trauma and the long-term effects of trauma. I will be sharing that resource with you at the end of today's presentation. And about 76% of people that have experienced 5, or from that same study, we look at 8 different types of trauma. And for those people that experience 5 or more traumas, 76% of them report having 1 or more delays in their language, emotional, or brain development. So some kind of delay in their brain development throughout their lifespan. Now, I want to make a parenthesis here, and I do want to talk about the majority of this reporting has been done around the neurotypical population. And so we will be addressing trauma specifically when it comes to our atypical population. But for these standards, this is neurotypical population. And I will be talking a little bit about what the barriers are to getting accurate information and accurate data within atypical populations. Our children that are on the spectrum or have some sort of developmental disability, right? But I also want to make a very special note here that not everyone that experiences a traumatic event will develop trauma symptoms. So, and what do we mean by trauma symptoms? I'm going to be getting a little bit more into that, but not everyone that experiences trauma will actually experience PTSD, right? Traditionally, when we think about trauma, we make the automatic association, or we may or may not make the automatic association with PTSD, but there's multiple and varied forms of intersecting with trauma, right? But people who have experienced trauma are 15 times more likely to attempt suicide. They're 4 times more likely to become an alcoholic, 4 times more likely to develop a sexually transmitted disease, 4 times more likely to inject drugs, 3 times more likely to use antidepressant medication, 3 times more likely to be absent from work, 3 times more likely to experience depression, 3 times more likely to have serious job problems, 2.5 times more likely to smoke, 2 times more likely to develop chronic obstructive pulmonary disease, and 2 times more likely to have a serious financial problem. And so there's different theories around this and different theories on why or how this happens. But the data suggests all across the board that trauma has a long-term impact in trauma survivors, that there is something that happens in the brain, there's something that happens in the body that changes the body when we're exposed to trauma, right? There is something that happens that makes us a little bit more predisposed to certain situations. It changes our view of the world. It changes the way that we relate to others. It changes how we view safety and security. And so it changes quite a bit of things for us, right? And how do we diagnose trauma? So there are changes in mood and behavior, things like difficulty maintaining close relationships, feeling detached from our family and friends, lack of interest in activities that we once enjoyed, difficulty experiencing positive emotions, feeling emotionally numb, and having a heightened alert response. There's also an avoidance category, which is trying to avoid thinking or talking about the traumatic event. So this happens a lot, quite a bit with trauma survivors, that we may not necessarily want to think or talk about the event. And that actually leads to a lot of the other traumatic symptoms, right? But avoiding certain places or activities or things that remind you about the event. It may be a place, it may be a song, it may be a color. Like I've talked to trauma survivors that, for example, um, they get reminded of, for example, their sexual trauma by mustard, right? Like there was mustard in the room somewhere when they experienced sexual abuse, and so that might be something that constantly reminds them of it, and they will have a preference to avoid it. There's also some cognitive shifts. So there are negative thoughts about yourself or other people or the world. A lot of the times we may develop what we call cognitive distortions. We may feel like it was our fault, right? We may feel like there was something that we could have done to prevent it. We may feel like I should have been stronger. I should have done this. I could have done this. And so there's a lot of negative thoughts about how we could have or should have handled that traumatic situation. There's also negative thoughts about other people, right? So we may come to think that all men are bad, or we may come to think, I'm one of the only mental health providers in town, and I still have certain patients that may not necessarily want to have therapy with me because I'm a male. And so before we even start, that is a little indicative to me that, there might have been some kind of physical violence or sexual trauma in the past, and that may cause some of that resistance, right? We may also have negative thoughts about the world. We may have memory problems, including not remembering important aspects about the traumatic event, hopelessness about the future. And we also have another category of symptoms, which is called intrusion, which is recurrent, unwanted, distressing memories of the traumatic event. So these are things that kind of just pop into your head over and over again. You may get flashbacks, which is a little bit different than a memory. With a flashback, you kind of feel like you're back in the moment as if you were reliving it. You may have upsetting dreams or nightmares about the traumatic event. And you may have severe emotional distress or physical reactions to something that reminds you of the traumatic event. So, considering everything that I just brought up, I want us to consider the fact that so a lot of the research that has been done thus far has been on a lot of the long-term research has been done on neurotypical children. The ACEs study did a really good job at focusing on the long-term effects of trauma, which is one of the first of its kind, right? We knew that trauma was a thing, but the development of trauma studies is a relatively new field. If you can think about the concept, for example, of mental health. Mental health is a relatively when it comes to medicine, mental health is a relatively new concept and new field. Within that field, there's pockets of the field that have more development than others, right? And so trauma is a big one there. Um, we actually didn't start to address trauma and actually look at trauma as a real thing until the 60s and 70s. And past that, our view of trauma and the way that we treat trauma has it's really lagged behind when it comes to other things like depression or schizophrenia, anxiety in general. And so there's a little bit more of a lag there when it comes to some of the data that has become available to us. Now, given all of those considerations, you also want to think about the fact that um, whenever they did start to evaluate different forms of trauma, that the majority of the research was based on neurotypical children. So there is already a big push. There is we can acknowledge and identify that there is differences when it comes to a neurotypical child's experience of trauma and someone who is on the spectrum, for example. And depending on their what their socialization and communication looks like, we may or may not have differences in the way that they experience the actual trauma itself. We may also be susceptible to different types of trauma that we may not consider a traumatic event for a neurotypical child. So we're going to take an in-depth look at that. So what makes our population a little bit more vulnerable to trauma? So one of the main reasons why when we look at trauma, we've really, a big part of trauma focus is based around children is because children are already a vulnerable population, right? Because of their reliance on their caregivers, and this um, their developing brain. There's something that we need to look at when it comes to their vulnerability to trauma. But when we're looking at atypical children, there's an even heightened level of vulnerability. And so I want to take a look at different things that make our population just a little bit more vulnerable. There might be a higher level of stress, right? Depending on where you're at and who you're with, you may or may not experience more financial difficulties, right? So if you have to pay for more doctor visits or you have to pay for more caregivers, you may have some kind of financial difficulties. Your parents may have already been experiencing financial difficulties already, and so there might be a high level of stress in the home. Parents may be going through their own grieving process, right? And so as the child is adapting to different environments and just getting a little bit more acquainted with the world around them, the parents have to process their own grieving process, which may or may not be well adjusted, right? I think that the majority of the parents that are seeking out these resources, to me, that lets me know that your process is within the spectrum of being what we would call well adjusted, which means I'm coming to terms with it. I want to understand what this looks like for me, and it's not that you're grieving. That you're grieving anything related to your child. The fact is that you may have had this concept of what your child was going to be like, and your child may or may not fit that mode, right? And so parents may find themselves in a constant state of grief And so processing that individual grief for each of those things that your child may or may not live up to, um, of whatever your expectation was before, managing all of those different grief processes. There might be some familial tension, right? So it happens quite often when I'm treating families that, maybe one of the a child within the family may feel a little bit left out or may feel neglected. It may happen that one of the children feels overly responsible for the other children in the home. It may happen that there's tension due to the way that money is being spent. There's a whole bunch of different family dynamics that may or may not arise, um, that might complicate the dynamics in the home, making it a little bit more and making it a little bit more susceptible to different types of vulnerabilities, right? We also may experience some types of challenging behaviors. And I do want to make a note here that this does not mean that for any child, having challenging behaviors means that um, that it's your fault, or that the trauma is in any way your fault. But it does make you a little bit more vulnerable in the sense that it may raise that level of tension, and it may put us in a situation in which things are a little bit more difficult and more challenging, right? And so you may be experiencing a child that is struggling with aggression, elopement. This is the concept of maybe your child runs away, right? Um, non-compliance, right? Incontinence, self-injury, obsessions or compulsions. Each of these behaviors, depending on how much they're present, may or may not cause situations in the home that might make the child a little bit more vulnerable to different types of trauma. We also have communication deficits. And so we want to always make sure that we understand that your child's behavior is communication. And so, depending on how verbal your child is, you always want to listen. And actually, I will go as far as to say this is definitely the case for neurotypical children as well. That we want to make sure that we understand that behavior is communication. And so, whenever you see your child acting out, or whenever you see a heightened level of temper tantrums, whenever you see more aggression, all of that is communication. So we want to make sure that we understand what does that mean, right? Um, Especially for those folks that are a little bit less verbal, we want to make sure that we understand like what is my child trying to tell. We also another thing that makes this population vulnerable is there's less input on surroundings. So if I cannot tell you as easily that I do not like to be hugged, um, there's a little bit less input, right? Like there's a little bit less say so in the way that I get treated. There's multiple systems of care. So there's multiple adults and caregivers involved in care, and there's also multiple opportunities for disruption, right? So maybe you're moving, you're changing schools quite a bit, or maybe your school is experiencing a shortage, and you may go through several caregivers in a short amount of time. Maybe you have you're seeing an occupational therapist and a speech therapist and a psychotherapist and an ABA therapist, right? And depending on what your area looks like and how much resources you have available to you, you may or may not experience disruptions in care. So I want us to consider, we're going to go back here just for 1 sec, and I want us to consider all of these situations, right? So violence, abuse, neglect, natural disasters, physical pain, injury, illness, all of these different types of precipitating events that we have for a neurotypical child. And then I want us to consider the fact that there is different things that we may not traditionally consider that might affect a child in a traumatic way. So things, sensory experiences, right? And I don't know if anybody that's in our audience may or may not have considered how traumatic the overwhelming sensory experiences might be for your child. I was in preparation for today's presentation, I was reading up on someone's experience throughout a domestic violence incident, right? And this was one of 15 cases that got tracked throughout a really long time. But actually, in this particular case, the child was later on able to verbalize that the loss of the family pet, and as well as the disruption in routine, ended up being what was the most traumatic versus the actual domestic violence that was being experienced, right? And so we want to make sure that, number one, and trauma is already a very individual thing. What's traumatic for me may or may not be traumatic for you. And so while we make lists and we may say, this is trauma or this is not trauma, I want us to consider that for sure, that trauma is a very individual process, and it may or may not apply to you in the same way. My experience of trauma, what I would consider trauma at a level 10, may not necessarily be as traumatic for you, right? And so experiencing different types of violence may or may not be more traumatic for you than it was for me. And along the lines of that, I want you to think about what it might be like for a child to experience, and it's not just fire alarms, right? But like, for example, being exposed to maybe family members forcing you to eat something that you don't want, forcing you to wear something that you don't want, any type of sensory experience that is that our children come into contact with, anything that they're experiencing this overwhelming sensory experience that may not traditionally be seen as something that's traumatic. So people's behavior towards them, that is also traumatic, right? So due to less input in establishing boundaries, I was just looking at a little video this morning of a teacher's chart, and she had this heart for a hug. I think it was some hands for a type of handshake, and a little musical note for a dance. And that's how she would greet her children. And the children would get to choose by kind of pressing on the image next to the door, and they would kind of signal to what type of how they wanted to be greeted that day. Unless we have those opportunities for our children to effectively establish those types of boundaries with the world around them, we do get a lot of those missed opportunities, right? A simple hug may be very traumatic for them. something that is, for example, we talked a little bit right now about, being forced to eat something that they may not want. Um, that does happen. I know that it happens quite frequently within Hispanic cultures, right? That it's considered rude to not eat your food. That it's considered rude to not not eat all of your food, and that's kind of a big thing. It's also considered rude not to give hugs, or we have to say hello in a very specific way. Depending on what your surroundings look like, your child may have experienced at least one of these types of traumas in which they may have interacted with a family member in a way that was not necessarily affirming for them. We talked a little bit about the loss of a family pet, but not just a family pet. Any other serious disruption in routine can be seriously traumatic for a child. And then we have to consider the fact that there is more marginalization due to being socially different, right? And so that heightened experience of possible bullying, just being treated differently by others around them, getting weird looks, all of those sorts of things. So, how does trauma manifest for a child that has developmental disabilities, or is on the spectrum? So, we might see some regression in skills, and you may be able to see, for example, reenactment in play, kind of like this obsessive, repetitive. Um, so I do want to make a note here that is a very indicative. And so if you do see this reenactment in play, it's an important time for us to pay attention if we do see that our child is consistently reenacting certain situations, we do want to pay attention to what is going on there. Regression in communication or social skills, changes in sensory processing, and delayed independence. So anything that you've already made progress on, if you're noticing regression, it doesn't automatically mean that your child has experienced trauma, but it is something that you might want to look into, especially if you're noticing multiple regressions in different ways. Hypervigilance. They might be distressed by reminders of the trauma, and they develop an unsafe view of the world. And this is very normal for even neurotypical children and also adults. But you might notice this in your child as well. So changes in behaviors, you might see self-harm, violent episodes, especially in those that may have limited verbal skills. So we talked a little bit about how all behavior is communication, and so I want you to notice that. So the less access that your child has to verbal skills, the more that they may act out. And there's no coincidence with that. Like we want to make sure that we understand that our child is going to try to communicate no matter what. And so if you do see changes in that, and if you do see a high level of violent episodes, there might be something going on there. I remember I was working with a family that actually had two autistic children that engaged in both self-injury as well as violent episodes. And I was actually treating the siblings. I wasn't treating them. I was treating the siblings, and there was a high level of violent episodes in that family, just all across the board. There was a high level of violence, right? But there were certain things that would happen whenever a violent episode was going on, and a big part of that was that as the anxiety level started to raise in the home, the self-harming episodes um, for for these kiddos, it would raise. And so that was always very important for us to keep track of. Changes in response to peers or adults. And so you may see, if they had already made a little progress when it came to socialization, you might see a little bit of regression in that. You might see some antagonizing of adults or authority figures. But as I mentioned before, obviously a lot of what we talk about, a lot of what we address when it comes to some of the topics with trauma, a lot of it is really, really heavy. But what are some of the things that we can do after trauma? Does the experience of trauma automatically mean that we are just absolutely doomed and there's nothing we can do about it? Absolutely not. So there's a whole bunch of things that we can do. And I've categorized them depending on what, who the person is, right? But for example, parenting skills. We do want to make sure if you are a parent, there's a whole bunch of things that you can do. Number one, education. So that's just by simply listening to this conversation and seeking out this resource, you're already way ahead of the game, right? So the fact that you are seeking out this education, you are learning about the intersection between trauma and your child. How can I figure out what this looks like as it pertains to me? Behavior management, and I get this question all across the board. It doesn't matter what the child is going through. Parents sometimes feel the need to suspend their parenting because their child has been through some form of trauma. No matter what, it doesn't matter what your child is going through, the parenting never stops, right? So you always want to make sure if there was a rule set, those rules stay in place. So anything that you're already doing for behavior management, that has to continue, right? We cannot go a little bit more relaxed on the behavior management just because we know that our child has been exposed to trauma, right? And so it doesn't mean that you get an extra cookie or that you get more playtime or that you get to not do your homework. And as I mentioned before, like it doesn't matter what the child is going through. This is a big thing that I get with parents just all across the board. And so it is important to make that note. The behavior management continues, as well as the emotion regulation. We want to make sure that we continue to teach our child how to regulate their emotion and how to identify emotion. Emotional regulation is a big is a big technique within the type of work that we do. But then also to emotionally regulate for yourself, right? If your child has been through some kind of trauma and you're already aware that your child has been through some kind of trauma, it may or may not interact in a very specific and unique way with your own trauma. And so if you've been through trauma yourself, there's something that may be coming up for you. I highly recommend emotional regulation for yourself, right? And so that may be through, I'm going to seek out for help. I may contact a therapist. I'm going to get myself into therapy. I may call up my mother and, just have a conversation with my mother. I may seek out spiritual guidance, whatever that looks like for you. Just make sure that you're seeking out that emotional regulation, not just for your child, but also for yourself. You want to make sure that you are actively engaging in your coping skills and that you're also teaching coping skills to your child. The best thing to do is what I call modeling, which is actually showing coping skills, right? And coping skills is very relative to trauma. We talked about trauma being a very individualized process. It's the same with coping skills. The coping skills that work for me may or may not work for you. And so finding the coping skills that work for you and teaching your child to have a little toolbox of things that actually work for them, that's going to be super, super important. You also want to make sure that you teach your child what we call body rights, right? And so I get to choose. We talked a little bit about, that greeting that I was looking at before, right? I get to choose. Do I want a hug today? Maybe today I don't want a hug, right? And that's okay. Even though um, my cultural construct says that hugs are acceptable. Maybe I just don't like hugs, right? And that's okay. How do we teach our child to advocate for themselves and say, this is not something that I like, or maybe it is something that I like, right? And so finding a way to teach what feels best for them. If you are a provider listening to this conversation, um, I wanna make sure that we take note of the fact that just like with anything else, treatment needs to be tailored um, for our clients, right? And I think that a lot of the times there's there's a little skepticism when working with whether it's children or adults that are on the spectrum. That there might be kind of like this underlying notion that we're not able to treat, right? That we have to refer to an ABA therapist. But as long as we have the following three components, there is multiple ways and multiple approaches in which we can do this. Tailoring trauma-focused cognitive behavioral therapy to treat someone with IDD or or ASD. We can definitely do that as long as we're able to change the narrative, right? The same thing that we do for the neurotypical child or the neurotypical adult is change the narrative. What does this mean to me, right? As long as we're able to do that, and the way that we do that is going to look a little bit different. And so just seeking out different ways of doing that, right? Depending on what is presenting to you in session, right? But as long as you're able to change that story, as long as you're able to expose the child or adult to their own story, right? So be able to talk about it comfortably, be able to talk about it with others, be able to experience it in a different way, be able to expose yourself to that avoidance. And as long as you're able to coordinate safety planning, definitely treatment is available and is possible for you to provide this type of treatment. For the trauma survivor, you want to make sure that they're being educated in a relevant way, right? Like in a way that makes sense to them. You want to make sure that you educate them on the trauma. You want to teach relaxation techniques, teach them to seek out emotional support, and encourage them to engage in the exposure. So, as a provider, you can assign exposure, but it's going to be up to the trauma survivor to actually take note of that, right? And for our systems of care, anybody else that is involved in the care of the child, this may be a babysitter, it may be grandmother that gets to have them, for a few hours every other week, right? It may be the uncle that lives in that home. It may be the occupational therapist. It may be the daycare center. It may be the school. It may be the principal. Anybody that is involved in systems of care. The more people that we can get involved, the better. You want to make sure that they participate in safety planning. That your child has the opportunity for reduced isolation, and you want to let them know, a lot of the times parents do a really good job of looking up the highest standard of care, right? And what can I do to help my child in the best way possible? And you invest all of this time and money and effort into finding out the best way to parent your child, and then you don't get that buy-in from the rest of your family or your extended family, right? And so it's super important that we get to, if nothing else, that we get the buy-in on this, right? That our family members understand what we're doing with body rights, right? Um, some cultures, it may be a little bit easier than others. I know that, for example, in my culture, it's particularly difficult, right? Like, how do I teach my 80 something year old mother that I'm teaching my child body rights and he gets to say no to a hug? Like, that's a difficult cultural challenge. And I acknowledge that, but, trying to get that buy-in. Um, and trying to foster that independence, right? So the more independence that we have, the better. The less opportunities for trauma that we have available. And so that concludes this presentation. I will be sending out a separate document with all of the resources that were used and all of the references that were used for this. And then just a little bit more on I would encourage all of you to read up on the ACEs, the Adverse Childhood Experiences. This has been a long-term study on trauma. And as I mentioned before, a lot of this is as it applies to the neurotypical child, but it's a good baseline for us to understand that more than likely a lot of what may happen with the neurotypical child may also be happening with your child as well. There are a couple of resources that I'm sending out that are very specific to IDD and ASD, and so those are also, very, very specific to this type of population. The data is still developing around that. We have some, right? We have enough to understand that there is some differences, there is some correlation there, and there is also a little bit of differences in the way that we treat it. But a lot of this is continues to still be developed. I want to thank you so much for your time, and I hope that this resource is of use to you in the future. Thank you.
Thank you so much. We'll make sure to link all those links for you below, and we really enjoyed listening to your presentation and just hearing everything. I have a background in ACEs, and I love hearing you mention it. One of the best ways to learn about ACEs and kind of dive into that, there's a really great documentary out there, Paper Tiger. And so watching that kind of really opened up eyes for me when I was an educator into knowing how trauma informed therapy, and just really learning some of those tools and with students to help. But Mr. I loved everything that you said. I love the terms you used. I think really also looking into our disability community, understanding the marginalization that we have. And I really like the evidence-based practices that you pointed out with the modeling. I think that's one of the key components in life, is just immersing yourself around an environment with people that are modeling those good coping skills and behaviors. And so I find myself doing that quite frequently with myself and my son and my husband. So we love that. And we can just hear all the compassion in your heart for individualizing for your patients with those toolboxes and tools. So thank you for everything that you're doing. And we'll make sure to link your contact and information below. So if anybody has any questions or wants to reach out to you, we're just so thankful. So thank you.
Thank you. Thank you so much. And like I said, I'll be sending out a separate document for you to send out to your parents. And I'm not sure if you have other providers on here, but it definitely includes some resources for providers as well. I know that I remember a few years ago, Medicaid started sending me. Uh, they had cut ABA services, right? And so they started sending me, I guess, kind of like as a replacement for ABA. And I know that it can be challenging, right? Like, especially for those families that are not, maybe don't have the resources, or maybe don't understand how service delivery works, don't understand how to advocate for themselves, right? And that is traumatic within and of itself, right?
Yeah.
So being on Medicaid and losing resources, like what does that feel like, right? I mean, it's
Yeah.
already traumatic for somebody, living in an affluent community that has access to resources, but for someone that is dependent on Medicaid and may
Yeah.
not necessarily have those tools, right? Um, that's challenging. And so a big part of what I always do, I think it just comes secondary to working in rural communities, is I just have to teach a lot of self-help. I have to, parents have to understand that they are the providers, right? Like, they are the ones doing the treatment all the time, and and it's okay. And when we're adults, it's us treating ourselves, and that's okay, right? Like, how do I make this work on my own? Whenever there are no resources available, whenever I don't have access to that, what can I do to mitigate the impact?
Exactly, and that's one of the things with Eagle Pass Heroes that we've seen is just helping provide those resources in a rural area, and especially, when we look at it, and I've talked to senators on this too as well, when you look at the state of Texas that we're in, Maverick County and surrounding counties, we're known as a healthcare desert. And so, really grasping onto these and holistically providing your family with these resources is critical and key. And I really hope that we're able to share this video over and over to everybody and teachers, providers, and community members so that we're all hyper aware of how to help each other because we're all in this together. So thank you so much.
Thank you, Ms. Maurer, and we'll be in touch.